We discuss now the burial meal. Burial meal examination of the stomach and first part of the duodenum. The right-sided image represents a double contrast study of the normal stomach. Double contrast is the use of barium and used for gas. It is very good for demonstration of the mucosal outline. The anatomy of the stomach. The stomach is divided into fundus represented by the F, the body of the stomach the B, and the antrum of the stomach is the A. The linear translucency which is present within the body of the stomach lined by the arrowhead is called the rugae of the stomach. It is a normal fold of the stomach, and its absence or its destruction indicate usually abnormality of the stomach. The black arrow represents the lesser curvature of the stomach. The white arrow represents the greater curvature of the stomach. For preparation of the patient prior to the burial meal, the patient should be fasting for at least 6 to 8 hours. This time represents the gastric emptying time. Because the content of the stomach is solid, it could be adhered to the wall or to the lumen of the stomach, appear as a filling defect, and mistaken as being a carcinoma of the stomach. In the left side image, you can see there is a huge dilatation of the stomach, J-shaped stomach. As we say, any area of dilatation, we should search for distal obstruction. Here, the obstruction is present within the pyloric canal. This narrowing is short in segment. It is irregular in outline. It producing shoulder sign as its attachment with the first part of the duodenum and at its attachment with the antrum. So this is most likely gastric outlet obstruction due to carcinoma of the stomach. Another common cause for gastric outlet obstruction is cases of chronic ulceration of the antrum, pyloric canal, or the first part of the duodenum. You can see also here, this is also area of narrowing involving the distal part of antrum at the beginning of the pyloric canal. It is short segment, irregular in outline, producing shoulder sign and its attachment on both sides, and this is most likely a case of carcinoma of the stomach. Here in this burial meal, you can see also dilatation of the stomach, but in the absence of marked obstruction distally. In the superior portion of the antrum, you can see a smooth, well-defined filling defect indent the lesser curvature and the uppermost portion of the antrum. This smooth filling defect is producing a characteristic sign called the thumbprint sign. This sign, if occurred within the stomach, it is most likely indicate a case of lymphoma of the stomach. You see here there is a narrowing in the distal part of the antrum and within the pyloric canal. It is irregular in outline, short segment with dilatation of the stomach. This is also a case of carcinoma of the stomach. Now we discuss the gastric ulceration. Gastric ulceration, you can know, could be benign and could be malignant. Two image in two position is taken for the assessment of gastric ulcer is the in-face projection and the in-profile projection. In in-profile projection, the ulcer will appear, a benign ulcer will appear as outpouching of contrast arising from the wall of the stomach. You can see there is, in this form, there is outpouching of contrast arising from the lesser curvature of the stomach. It is small in size, smooth, regular in outline, so this is most likely a benign gastric ulceration. There is a thin translucent well-defined regular line represented by the red arrow separating the contrast in the ulcer and contrast within the body of the stomach. This line representing mucosal edema, and it is called Hampton's line if it is a thin pencil line. If this line is thicker, it is called the ulcer collar. It is usually indicate acute ulceration associated with mucosal edema. In this film, you can see a large filling defect involving the greater curvature of the stomach. There is also irregular collection of barium seen within the dependent portion of the antrum. This is most likely a case of a malignant ulcer. Malignant ulcers tend to arise within the outline of the stomach, not protrude outside the outline of the stomach. You can see the large size, the large collection of the contrast, and the dissection of the mucosa. So this is most likely a case of malignant ulceration. When the carcinoma of the stomach become large, it will protrude into the lumen of the stomach as a mass or as a filling defect with irregular outline. You can see in this film, represented by the black arrow, there is a large filling defect occupying the antrum of the stomach. It is irregular in outline. This is most likely also a case of carcinoma of the stomach. This is a barium meal in an infant. The spine of this patient indicate this is a child or an infant spine. In this image, you can see a huge dilatation of the stomach. This is a huge dilatation associated with narrowing within the pyloric canal. It is short segment narrowing, smooth, regular in outline. In an infant less than 3 months age with non-projectile vomiting, this narrowing and obstruction mostly caused by infantile hypertrophic pyloric stenosis. Shoulder sign present within this film. It is not due to malignancy, but because of the hypertrophied muscle of the pyloric canal will indent the first part of the duodenum and appear as a shoulder sign. You know that the first radiological investigation for any patient suspected of infantile hypertrophic pyloric stenosis is by ultrasound, because it is safe, non-ionizing radiation, comfortable, not required preparation for the patient, and it can produce high rate of sensitivity and specificity. You know the sign in ultrasound. Muscle width greater than 4 mm, length greater than 16 mm, peristaltic antrum with absence of passing of the content into the first part of the duodenum. All of these signs indicate a case of infantile hypertrophic pyloric. This is a barium meal, and this arrow representing the first part of the duodenum. The characteristic appearance of the first part of the duodenum is cup shape. In this film, you can see a collection of barium seen within the center of the duodenum. This collection of barium is smooth, regular in outline, with smooth mucosal fold extending to its margin. This is a duodenal ulcer, and this image is an in-face image where the ulcer is occur as a collection within the center of the duodenum or within the center of the stomach. In this form, the lesion present within the dependent part, يعني الجزء اللي راح يتجمع به الباريوم. If we turn the patient, the ulcer will occur in the non-dependent part, so it is occur as an area of translucency surrounded by contrast. So the appearance of the ulcer on an in-face image depend it is present within the dependent or the non-dependent portion. Now we come to the large bowel. Examination of the large bowel is called the barium enema. As we said, it is performed through a rectal catheter. It is a retrograde study, could be single contrast or better done as a double contrast study. You know that the large bowel is divided into cecum, ascending colon, transverse colon, descending colon, sigmoid, and the rectum. The highest portion on the left side is called the splenic flexure. The highest point on the right side is called the hepatic flexure. The characteristic anatomy of the large bowel is the presence of fossa, which is thick, incomplete mucosal fold. Differentiate a large bowel loop from a small bowel loop, which has the valvule conjunctivis, which is thin, complete mucosal fold. For barium anemia, the patient should be prepared. This preparation is called 3 days preparation. It is resemble the colonic preparation prior to surgery, but it does not require the use of medication. Not required use of antibiotic. The patient should be kept for semi-solid diet in the first day, second day semi-fluid diet, and in the third day on the fluid diet, do enema for the patient, and keeping the patient fasting per night. Colonic preparation is important prior barium study or prior to CT study of the colon, because the solid content may adhere to the wall, present as a filling defect, and can misdiagnose as a carcinoma. In this film, you can see a presence of area of filling defect or area of narrowing involving the junction of the transverse colon and the ascending colon. It is short in segment, irregular in outline, producing shoulder sign on both sides. This is a case of carcinoma of the colon. This appearance is characteristic called the apple core appearance of the colon. It is occur in cases of annular carcinoma of the colon. This is a barium enema showing a large filling defect involving the cecum. It is irregular in outline, associated with destruction of the mucosa. Such appearance of large filling defect within the cecum produce the suspicion of carcinoma of the cecum. In this case, the most likely growth appearance of the carcinoma is ulcerative type of carcinoma. You can see here there is a large filling defect involving the descending colon close to the junction with the sigmoid colon. It is irregular in outline, producing short segment narrowing. This is most likely a case of carcinoma of the colon. In this film, you can see the fossa is appearing very clear. It is thick, irregular mucosal fold. So different appearance of the carcinoma of the colon depending on its growth. It could be annular type, producing characteristic apple core appearance. It could be ulcerative type, producing a filling defect. It could be a fungating type of carcinoma, and fourth appearance is the cauliflower type of carcinoma. Also, this is a barium enema showing short segment narrowing. Mostly it is in the sigmoid colon. It is irregular in outline, producing shoulder sign and apple core appearance. This is a barium enema. You can see there is a multiple outpouching of contrast arising from both sides of the wall of the sigmoid and ascending colon. It is different in sizes, well defined in margin, smooth, regular in outline. This is mostly due to diverticulitis. Diverticular disease of the colon could be divided into diverticulosis, which is asymptomatic, and diverticulitis, which is inflammation of the diverticuli, and usually it is asymptomatic. Many complications associated with diverticulitis, such as parachoric abscess formation, fistula formation, bleeding, carcinoma is a rare complication of diverticulitis. In diverticular disease of the colon, the diverticuli are usually acquired, not congenital. It is usually a false diverticulum, not a true diverticulum, and it is of different sizes. In the normal colon, the hosra tend to disappear gradually within the sigmoidal colon and within the rectum. In cases of diverticular disease or motility disorder of the colon, the hosra will be exaggerated within the sigmoid colon. This is a double contrast barium anemia. You can see there is complete absence of the hostration from the sigmoid, descending colon, and mid of the transverse colon. You can see the thin wall of the colon. This is most likely a case of ulcerative colitis. The earliest appearance of ulcerative colitis is the fine granularity of the mucosa, followed by absence of the hostration, narrowing and shortening of the colon. Ulcerative colitis almost always arises in the rectum and extends upward in a continuous fashion. Here you can see involvement of the sigmoid, ascending and mid of the transverse colon. The remaining of the colon is normal, not affected by the disease. In this case, this is a pancolitis. All of the colon is involved by the disease. You can see the granularity of the mucosa, complete absence of the hosra, shortening and narrowing of the colon, producing the characteristic lead pipe appearance. In this film, you can see the passage of the contrast into the distal ileum. Normally, in barium anemia, the contrast should not pass to the ileum because of the presence of the ileocecal valve. So if the ileocecal valve is competent, no contrast would pass into the small bowel. While in case of incompetence of the ileocecal valve, such as in pancolitis, the valve become incompetent, the contrast will pass into the distal ileum, and the condition could be associated with backwash ileitis, which is involvement of the distal ileum by the disease process. Another complication of ulcerative colitis is carcinoma, usually occur within 10 years of presentation in cases of pancolitis, so most of the patients should enter the colonic surveillance program for carcinoma. So this is a characteristic granularity of the mucosa, lead pipe appearance associated with backwash ileitis. The acute fulminant presentation of ulcerative colitis is toxic megacolon. We say that barium study is contraindicated in cases of toxic megacolon. The only tool for diagnosis of the condition by performing a plain abdominal film. This is a plain abdominal film showing huge dilatation of the transverse colon. Measurement of the transverse colonic diameter greater than 5.5 cm or 6 cm is diagnostic for ulcerative colitis with toxic megacolon. This is a barium meal. You can see a large pouch of stomach is extending into the mediastinum and into the thoracic cavity. This is most likely a case of hiatus hernia. Hiatus hernia is an acquired type of hernia. The commonest type of it is the sliding hiatus hernia. So this is most likely a case of sliding hiatus hernia. Hiatus hernia or sliding hiatus hernia is diagnosed if a pouch of stomach extending greater than 2.5 cm above the diaphragm, containing 3 or more rugae. In this film for an infant, you can see presence of multiple gas containing bowel loop extending into the left thoracic cavity. This multiple gas-containing bowel loops associated with shifting of the mediastinum into the contralateral side. You can see the presence of the cardiac shadow within the right side of the chest, not in the midline or in the left side of the chest. A continuation of the gas-containing bowel loop seen extending from the abdomen into the thoracic cavity. This is most likely a case of a congenital diaphragmatic hernia. The commonest congenital diaphragmatic hernia on the left side is the Bogdalic hernia, characteristically associated with shifting of the mediastinum into the contralateral side. Bogdalic hernia is regarded as an emergency condition because it could be associated with respiratory distress syndrome of the infant within 2 to 3 days of life. I complete the session. If you want to ask any question, I am ready for your questions. Thank you.